Hello friends, in my recent video on CSF examination, some viewers suggested adding more details about the lumbar puncture procedure. So, in this short video, I will focus exclusively on lumbar puncture, covering its indications, contraindications, procedure, and potential complications. Stay tuned. A lumbar puncture, also known as a spinal tap, is a medical procedure in which a needle is inserted into the lower back, lumbar region, to collect a sample of cerebrospinal fluid for testing or to administer medication. A lumbar puncture is performed for both diagnostic and therapeutic purposes. The most common reason is to collect a small amount of CSF for testing. This helps diagnose conditions such as infections like meningitis and encephalitis, certain cancers affecting the brain and spinal cord, subarachnoid hemorrhage, which is bleeding in the space between the brain and its protective layers, demyelinating diseases such as multiple sclerosis, Guillain-Barré syndrome, where the immune system attacks the nervous system, neurosyphilis, an advanced stage of syphilis affecting the central nervous system, for diagnosis and prognosis of Alzheimer's disease. Additionally, lumbar puncture is used to inject medications directly into the spinal canal, such as spinal anesthesia before surgical procedures, chemotherapy drugs for treating certain cancers, contrast dyes for imaging studies like myelography and cysternography. A lumbar puncture should not be performed in the following conditions: infection at the puncture site, as it may spread to the subarachnoid space; midline shift, which indicates high intracranial pressure and increases the risk of brain herniation; coagulation abnormalities, which can lead to bleeding complications. The spinal cord, conus medullaris, usually ends at the lower border of L1 or the upper border of L2 in adults. To avoid injuring the spinal cord, lumbar punctures are typically performed between L3 and L4 in adults. In newborns, where the spinal cord extends further down, the puncture is performed at L4 to L5. The patient may be positioned in one of two ways: lying on their side with the chin tucked to the chest and knees drawn to the abdomen, sitting on the edge of a table, leaning forward with arms resting on a surface. In both positions, the goal is to widen the spaces between the vertebrae, making needle insertion easier. A useful anatomical landmark for lumbar puncture is Taffier's line, an imaginary line connecting the tops of the iliac crests, which crosses the L4 spinous process. During the procedure, the needle passes through the following structures: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura mater, arachnoid mater, subarachnoid space, where CSF is accessed. Greckenstedt's test. This clinical maneuver, performed during a lumbar puncture, involves compressing the jugular veins to observe changes in cerebrospinal fluid pressure. It helps diagnose spinal blockages or stenosis. In a normal spinal canal, jugular compression raises lumbar CSF pressure, which returns to baseline when the pressure is released. In spinal stenosis or obstruction, there is a delayed or absent response. However, this test is now largely replaced by advanced imaging techniques like MRI and CT scans. After a lumbar puncture, patients should lie flat on the bed to minimize the risk of headaches. If a headache develops, the patient should not sit up. Instead, the foot end of the bed can be raised to help redistribute CSF. The most common complication is post-lumbar puncture headache, caused by cerebrospinal fluid leakage from the needle insertion site. Other possible complications include infection at the needle insertion site, bleeding within the spinal canal, local pain at the puncture site. That concludes our discussion on lumbar puncture. I hope this video provides clarity on the procedure.